Morning, everyone. I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll get started with just a couple reminders and then announcements and introductions for today. Next week, there will be no grand rounds, so please enjoy the Thanksgiving break. And then we will return the following Tuesday, November 28th, when we will be hearing the topic Sexual Health and Chronic Illness, a Biopsychosocial Approach. So a few logistics. Grand Rounds is now a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are always available on the Teams Live platform virtually, and we often try to meet in person, usually Tuesdays at St. Vincent and selectively on Wednesdays at Providence Portland, particularly when we have visiting lecturers. You can earn CME credit by being with us here in person, by watching the virtual live event, or by watching a recording of the session. And just a reminder that recording is always available at the same link as the Grand Rounds invite. So I will be monitoring the Q&A throughout today's session. Please go ahead and post any questions or any comments you have for our speaker, and I will mostly hold those until the end as time permits. And now I am particularly delighted to introduce today's very special lectureship. We have the 2023 Kammer Lectureship in Endocrinology. For those of you who do not know, Dr. Kammer was the first board-certified endocrinologist here in Oregon and an icon at Providence Portland Medical Center and the broader Providence community for over 45 years. In addition to managing a busy clinical practice, he also conducted high-quality clinical research and served as Associate Program Director for the Internal Medicine Residency at Providence Portland for over 30 years. Dr. Kammer's tireless dedication to clinical excellence and scholarship was an inspiration for students, residents, and his fellow practicing physicians. And it is truly in his honor that I am so excited to introduce today's speaker for the Kammer Lectureship. We are joined by Dr. Catherine Martin, who is Assistant Professor of Medicine at the Harvard Medical School, a longtime faculty member, investigator, clinician, and educator in the Reproductive Endocrine Unit within the Department of Medicine at Massachusetts General Hospital. In addition to her clinical practice, she has an active teaching role that includes the training and supervision of junior faculty and endocrine fellows. Dr. Martin is also Senior Physician Editor for Endocrinology and Metabolism at Up to Date. Her clinical research interests have focused on a variety of reproductive endocrine topics, including menopause, and she has written and lectured nationally and internationally on issues relevant to menopausal women, and has co-authored reviews in key journals such as the New England Journal of Medicine and Science. Dr. Martin has held a number of leadership positions within the Endocrine Society, including the oversight of 15 new clinical practice guidelines. And in 2022, she received one of the Endocrine Society's prestigious laureate awards, the Outstanding Educator Award. And so I am so happy to have Dr. Martin join us today. Please give her a warm welcome.
Thank you so much. What a lovely introduction. And I'm truly honored to be here to give this lecture. Last night I was reading a bit about the Kammer family, what an incredibly remarkable family of physicians and scientists. So I am truly honored. Let's see here. My one conflict of interest is that I am an editor at Up to Date. I just found out that some of you are my SGIM reviewers, and so I have to really be on my toes. So the learning objectives, I think some of you have already seen these. What I'm going to try and do during the hour, and I will leave plenty of time for questions, is review the clinical manifestations and diagnosis of the menopausal transition and menopause, identify the indications and candidates for menopausal hormone therapy. MHT is the term that we currently use. We no longer use the term HRT, or hormone replacement therapy. The rationale for that is back in the 70s and 80s when we were using hormone therapy to prevent disease, we thought of it as replacement therapy, replacing estrogen to, get women back to the premenopausal state and they could live forever, etc. But we still use the term HRT for women with early menopause, primary ovarian insufficiency. But for women who are in the transition or post-menopause, we use the term menopausal hormone therapy. Nobody gets in trouble if you use the term HRT, but you're trying to make the language a bit more systematic. Also review some of the optimal regimens that we use. And when you're starting someone on therapy, you really want to base it on where they are in the menopausal transition, or are they postmenopausal? What's the timing? And then I'll review some of the non-hormonal therapies for women who are not able to take hormone therapy, in particular, women with breast cancer. And then I'll say a few words about the role of androgen therapy in postmenopausal women. There's not a big role, but I will review it because it comes up all the time with our patients, and I'm sure that's true in your practices. I'm not going to review in any detail the Women's Health Initiative. It's now over 20 years since the initial publication, and I think everybody knows sort of the bottom line of what was good about it, what the limitations were. So we won't spend time on that. The major issues that I see in this field are that those initial results published in 2002 from the Women's Health Initiative continue to dominate the landscape of hormone therapy, which is pretty astonishing. And we'll go over that in a bit more detail because it's so well established that the benefits of hormone therapy outweigh the risks for women with symptoms between the ages of 50 and 59, or women who are less than 10 years post-menopause. We probably know more about the risks and benefits of estrogen than we do about almost any other drug, but there's still tremendous resistance to prescribing it. Hot flashes have a very important impact on health, on quality of life, and they last a very, very long time. So duration of therapy should be individualized. Back in the day when I first became interested in menopause, the conventional wisdom was that hot flashes are sort of a nuisance. They last for a year or two and then they go away. But as all of you know, they, on average, hot flashes last for 7 to 10 years, and for many women, 20 years, 25 years. And so when you're thinking about managing hot flashes, duration is so important. And then symptomatic women, perimenopausal and women postmenopausal, are woefully undertreated in the United States. It's really stunning that in spite of all the reassuring data, safety data, very few women get hormone therapy. Women with severe, severe symptoms, women who are terrific candidates. Two things driving it. Women don't get asked by their providers. And I think part of that is if you ask about symptoms, then you have to counsel about the options, which can take a long time. And with busy practices, it just doesn't happen. And there are other reasons as well. So come to the next slide. This is a slide I created just to give you a sense of the history of the percentage of women in the United States who have used hormone therapy. It's really been all over the map. In the early 60s, it first became popular for hot flashes. It was FDA approved for hot flashes, but it was driven primarily by one pharmaceutical company who hired an obstetrician to write a book called Feminine Forever. I'm not sure are people familiar with that book? Dr. McClellan, yes. It was really something. It promoted the use of estrogen to keep women beautiful, young. It had these sort of stick figures of postmenopausal women who didn't take estrogen and they were turning to dust and falling down in the street versus women who took estrogen and they were beautiful. And, so it drove prescription rates to the point where by the late 60s, at least 30% of women were taking estrogen. Doses were high. The only estrogen used at the time was conjugated estrogens, Premarin, because it wasn't known that it would be associated with endometrial cancer. By the early 70s, it became very obvious that unopposed estrogen was associated with endometrial hyperplasia and cancer, so rates dropped. But there were soon clinical trials demonstrating the protective effect of adding a progestin, so rates went up again and remained there for about 20 years, in the range of 35%. The rates of use are so variable geographically. There's ethnic variability, big variations, but white women in particular, they're much more likely to be prescribed estrogen, and rates in white women were probably 35 to 40% here. What was driving these high rates in the 1980s and 90s, as you recall, was the observation in epidemiologic studies that estrogen seemed to reduce the risk of coronary disease and cardiovascular events by about 50%. In retrospect, we know that that was likely a healthy user bias, but I know at my institution, during my fellowship and the early years post-fellowship, if a woman was admitted to the hospital with an MI, she was sent home with estrogen therapy for secondary prevention. Women who were admitted for bypass surgery were sent home. It was in the orders, the discharge orders. So it, you know, it really was dogma that giving estrogen would prevent a second event and also prevent the first event. Then in 2002, we had the initial publication of the Women's Health Initiative. And as a result, use plummeted and down to about 4%. And we're still in that range. 20 years later, only 4 to 5% of women in the US are prescribed estrogen therapy, hormone therapy, which continues to astonish me. But there are many limitations of the WHI, which I won't go into, but their goal was not to look at the impact of hormone therapy on symptoms. Their goal was to look at the effect of hormone therapy for prevention of osteoporosis, prevention of coronary artery disease. What happened was the age of the population, the mean age was about 63. Women were obese. Most had type 2 diabetes. They were smokers. So it was a population that's not representative of the women who come to the office to see you with symptoms. So why did the rates remain so low? I think part of the reason is that there continues to be negative messaging, lack of awareness of current evidence, and part of that relates to where the evidence appears. For the OBGYN community, they're much more likely to see menopause studies, for example, the journal Menopause, but in virtually any of the OBGYN journals, less so in the internal medicine journals. The guideline messages are very different. The North American Menopause Society, which is now the Menopause Society, publishes updated clinical guidelines on a fairly routine basis that talks primarily about the use for symptoms, and it's reaffirms that it's very, very safe. In contrast, what internists see are the guidelines from the United States Preventive Services Task Force. They have never looked at the impact of hormone therapy on symptoms. They continue to do the same analysis. They've now published 5 guidelines, 5 systematic reviews and meta-analyses, but the evidence base hasn't changed because it's all the WHI and a couple of other trials. And there are a couple of randomized clinical trials post-WHI, but they don't really change the message. So the message comes out every 2 to 3 years, and it gets a ton of attention in the lay press. Estrogen therapy, hormone therapy is dangerous. Don't use it. That's the interpretation. What they're saying is there's currently no role using it long-term for prevention of disease, although there are others who would disagree with that. So I think they'll probably stop doing that. They were so heavily criticized with their most recent update, which same numbers, same analysis. I think it's no longer the burning clinical question. Another issue is new trainees have little or no experience. And after the publication of the WHI, many programs, I know OBGYN programs, just dropped menopausal care from their curriculum. So it just wasn't taught. It wasn't taught in med school anymore. Same thing in internal medicine, although historically we tend to do less training about menopause with our trainees. But now these trainees learn almost nothing. The Mayo Clinic did a email survey a couple of years ago. They sent this out to every senior resident in OBGYN, every senior resident in internal medicine in the United States, and asked some really basic questions about menopause. The first one was, how ready do you feel when you go out into the real world to take care of menopausal women? And the internists, like 80% said, no, not at all. No, I've learned nothing. And the OBGYN residents, it was the same response. Then there were a series of questions, pretty straightforward questions about the use of hormone therapy. A 52-year-old woman who's healthy comes in, she's has severe hot flashes. What do you suggest? Internists, the vast majority suggested exercise or meditation. And the OBGYN population, those residents did better, but it really just showed how we're not doing a very good job, and that has to change. Fortunately, the whole area of menopause and menopausal medicine is beginning to gain more attention. Some of this is in the lay press. For example, I would highly recommend this article that was in the New York Times magazine earlier this year, written by one of their staff writers, Susan Dominus. And it was just a classic story about a symptomatic woman. She goes on vacation with a bunch of her friends. They're all the same age. They're all having horrific symptoms. They've all seen their provider. And every single provider told them, nah, I don't give estrogen. The writer, her doctor told her to take B or some kind of extract, which she tried and didn't work. And the rest, similar suggestions to take the options that are ineffective. And to a person, they had to bring up the fact that they were symptomatic because providers don't ask. And, I understand the reason for that, but it's our duty. Big consequences of not treating. Untreated hot flashes have very important consequences on quality of life, obviously sleep disturbances, and there's a tremendous economic impact. There have been a number of studies now, lost productivity at work, increases in heart disease, hip fracture, increased healthcare costs. Interestingly, there's a very recent focus on taking care of menopausal women in the workplace. I don't know if you've been seeing this. There are a number of studies saying if you're menopausal and you haven't slept in a year, sometimes your work suffers. That's not rocket science, but it's true. And there are some corporations now that are offering menopausal not care, but we care about you as a way to attract women in midlife to come and work for their company. Exactly what they do, I don't know, but it's becoming more popular. One unintended consequence of not prescribing estrogen is a dramatic increase in the use of compounded bioidentical hormones. And the vast majority of women who take the compounded hormones believe they're getting an FDA-approved product, which they're not. The compounded bioidentical hormone approach has many problems. It's extremely expensive. There's tremendous biochemical testing before and while on treatment. There are issues with, quality control, batch-to-batch variability, with a number of different things. But it's understandable how women are drawn to this. Theoretically, it's very appealing. And also, if they can't get, relief from what they're being given by their providers, they turn elsewhere. So what do we know in 2023? We know age at initiation is important. We already talked about that. Benefits do outweigh the risks in the vast majority of women who are the right age. There are meta-analysis after meta-analysis after meta-analysis, most of which actually show a reduction in mortality with hormone therapy and a small reduction in the risk of MI. So now I'm going to turn to a little bit to sort of the clinical features of menopause, how you diagnose it. Many women will begin to have their first symptoms in their late reproductive years, so maybe in their late 30s, early 40s. It's not been well studied compared to the menopausal transition and menopause. Before, prior to 20 years ago, we knew nothing about the menopausal transition, but there were subsequently a number of longitudinal prospective cohort studies, one in the US called a Study of Women Across the Nation. There were some in Australia, Europe, that followed women for many, many years, before the transition, all the way through the transition into their postmenopausal years, looking at bone density, gonadotropin levels, sex steroid levels, symptoms, etc. So it's given us a really good idea of what actually happens for most women. So the Stages of Reproductive Aging workshop has now met twice. I think they're about to meet for the third time to refine the definitions of the early menopausal transition, late transition, postmenopause. Menopause is defined as 12 months of amenorrhea, and that last period we refer to as the FMP, final menstrual period. So how do you know if somebody's in the early transition? It's defined by more than a 7-day difference in the length of consecutive cycles, so the intermenstrual interval. FSH is variable. Everybody ends up measuring FSH. It's not helpful. It's misleading. Do I measure it? Oh, yes, because It's people are referred, they want to have an FSH. So I understand, but I'll show you a slide of why it's not helpful. It changes minute to minute, day to day, week to week. So it's not a great diagnostic tool. The late transition is characterized by intervals of amenorrhea for over 60 days. This is when women start to get their most severe symptoms, hot flashes. Almost 85 to 90% of women during the late transition are symptomatic. And if you happen to measure an FSH, it's typically over 25. And then postmenopause is the final menstrual period. By that point, FSH is high. It remains stable for about 6 to 8 years, and it then actually declines. So there's a neuroendocrine component of aging. Interestingly, the transition is not really characterized by estrogen deficiency. Estradiol secretion is preserved through the transition. It's characterized more by low levels of anti-Müllerian hormone, inhibin B. Inhibin B is a good marker. I don't suggest measuring it clinically, but it's a granulosa cell product. It goes down many years before you see any change, consistent change in serum estradiol. So when we diagnose menopause, for women over age 45, it's a clinical diagnosis, as you know. Change in intermenstrual interval, menopausal symptoms equals menopause. Certainly you want to ask about other endocrine features or manifestations, but it's almost always menopause. And FSH measurements are not necessary. For women who are under age 45, it's important to rule out or round up the usual suspects for change in menstrual cycle or menstrual cycle dysfunction. So prolactin, TSH, FSH. Between 40 and 45, still it's usually menopausal transition. Under 40, you have to do a full evaluation, and about 1% of women will go through menopause before the age of 40, and that's primary ovarian insufficiency. That's a whole nother talk that's so interesting, and it's such a devastating diagnosis. We know so little still about etiology. It's probably going to turn out that almost all have a genetic basis. We're looking at different genes, but there's no role yet for genetic testing. But I think that day will come. And lastly, detailed biochemical testing, not necessary. The testing that's done sort of in a setting of compounded bioidentical therapy, where you get saliva testing or serum testing or urine testing and measure every possible steroid or gonadal steroid, every metabolite. You know before you measure it what it's going to show. Progesterone will be undetectable. All of its metabolites will be undetectable. Estradiol will be low, all of its metabolites. So it's not a useful exercise, but it's appealing when your provider says, well, I'm going to make you a mix of estradiol and this, that, and the other thing based on your results. So it is very appealing, but certainly I don't suggest it. This is a real simple slide. A study from a colleague of mine, Nanette Santoro, did many, many years ago. And it's a really nice picture of the endocrine changes of a menopausal transition. This is an individual patient followed for about 6 months. At the top panel, you have LH in blue, FSH in yellow. The dotted line here represents the upper limit of normal for premenopausal women. And then in the bottom, again, these are urinary studies, so you're looking at estrone and a progesterone conjugate. The estrogen is shown in pink and progesterone in yellow. And in general, whenever you see a big rise in progesterone, that means there's been an ovulation. So here, we assume that she had an ovulation, although we don't have the preceding data to see if she had an LH surge and estradiol rise. But then here, she's got a pretty normal looking cycle. So beautiful LH surge, preovulatory estradiol rise, and then a secondary rise in the luteal phase. And here's her progesterone level. You can see here her FSH intermittently is going out of the premenopausal range, which is quite typical. She then goes about 3 months without menses, and FSH is all over the place, no LH surge. And look at these. This is very typical of the transition, where because of the high FSH levels, women tend to recruit all sorts of follicles. They're all making estradiol, but there's no ovulation. There's no LH surge. The pattern is not normal. Women will experience breast soreness, and this sort of increase, decrease, the crashing of estrogen and the variable progesterone is associated with mood changes. Perimenopausal mood changes occur in about 50% of women. Sometimes it's recurrence of a prior depression, but it also new onset depression and anxiety is extremely common. The rates of depression and anxiety are the same for premenopausal women and postmenopausal women. It's a big rise in between during the transition that you see. It's very helpful to warn women, especially if they have a history of depression. This is what you're going to experience. You may get worse. In fact, they likely will get worse, but you can manage it. There's no role for not paying attention and treating the depression as they go through this transition. There used to be the conventional wisdom about depression in women was that you get to menopause, everybody becomes depressed because of the empty nest syndrome. And it turns out this is incorrect. There was a woman, Sonia McKinley, Dr. McClellan, you might remember her. She was one of the early investigators in menopause epidemiology, and she demonstrated that there is no empty nest syndrome. If there's a trigger for depression after menopause, is when those kids graduate from college and move back into the house. So, but rates of depression are not higher after menopause. It's this in between that's tricky. Symptoms, hot flashes is the predominant symptom, 85% of women. Many risk factors, obesity, genetic variants are beginning to be identified. The role of this, of knowing what your genetic background is it hopefully will be a predictor. Are you going to be someone with 5 years, 20 years, 25 years, so that you can, anticipate and plan therapy. Patterns and trajectories. This is a study from the Study of Women Across the Nation. And although I said that on average women have hot flashes for 7 to 10 years, in this population it was far more than 10 years. This is the trajectories of vasomotor symptoms, and they were able to categorize 4 different patterns that women may experience. Here on the y-axis is probability of hot flashes, number of years around the final menstrual period, shown here at 0. So 11 years before menopause, 14 years post-menopause. The top line, these are women who are considered to be have a high trajectory. 25% of women, their hot flashes start 10 years before and they continue for 25 years. So it'd be nice to know who those people are. But in general, they don't get treated, and the impact on their lives is profound. This group of 18%, they are the early onset hot flashers. Soon after menopause, they tend to improve. These are the late onset hot flashers, 29%. And there's a really fortunate group of 27% of women who tend not to have a lot of hot flashes. We know that's genetics, but don't know what the markers are. Mood disorders, I already mentioned. I would say, at least in my practice, almost all of these women end up on both estrogen and an antidepressant. I don't start both at the same time. It depends on what their predominant symptom is. If they're coming in with, depression, anxiety, I'll manage or address that first. If it's predominantly, terrible night sweats, hot flashes, I will treat with estrogen first, because if you can improve their sleep, then the mood symptoms will improve as well. Most of these patients do not tolerate progestins very well. Progestins can have an impact on mood, a negative impact on mood, so it can be challenging in this group. For choosing an antidepressant, the ones that are best studied in this population are citalopram, escitalopram, and duloxetine, which I don't use routinely. I typically use a low dose of an SSRI. Other symptoms. Sleep disturbances are really common, and this even independent of the hot flashes, night sweats. Night sweats are far more common than daytime hot flashes for reasons that are unclear. But most women will initially start getting sweating at night. But even independent of that, primary sleep disorders as well as depression, anxiety interfere with sleep. Joint pain is pretty common. So little is known about this, but the symptoms women often experience are very similar to the side effects of aromatase inhibitors. And so we presume that is related to estrogen deficiency. You give back estrogen, the pain goes away, you take it away, it comes back. As far as long-term management, there's just no information on how best to manage these patients. Estrogen-associated migraines get worse during the menopausal transition for most women because of the fluctuations in hormones, gets better after menopause. And vulvovaginal atrophy, which has a new term called genitourinary syndrome of menopause, GSM. And I think I have a colleague here who knows much more about this than me. She's a urogynecologist. That typically doesn't start during the transition. It's usually more years of estrogen deficiency before you see that. So when you're going to start hormone therapy, certainly review the history for contraindications and estimate 10-year cardiovascular risk and 5-year breast cancer risk. I will admit that I don't always do the cardiovascular risk calculation. If somebody walks in and she is, runs to the office and is incredibly healthy, almost everybody's going to be a candidate, but there are women, if their risk is greater than 10%, it's recommended to avoid hormone therapy. 5-year breast cancer risk, the cutoff for this is always moving, but in the Endocrine Society guideline, we said if your 5-year risk of breast cancer is greater than 3%, think non-hormonal therapies. I repeat the breast cancer calculation every time I see a patient because things could have changed. They might have had a biopsy. They might have a new family history. So just to be on the safe side. All of that said, the risk of breast cancer specifically related to menopausal hormone therapy is vanishingly small. And the North American Menopausal Society says there's really no appreciable change because we often, when we're thinking about it with our patients, we think of, well, maybe all these different risk factors all add up. They're not additive. And if you think of all the different risk factors for breast cancer, hormone therapy, the magnitude of change is so small compared to age at menarche, age at first birth, et cetera. So benefits, hot flashes, sleep, perimenopausal depression, joint pain. Benefits, fractures. There's a really big drop in the risk of developing type 2 diabetes. Do we give it to prevent type 2 diabetes? No, but it's the magnitude of effect is important. And a number of studies showing possibly a lower risk of heart disease and mortality. Breast cancer, no appreciable increase. I would refer you to the North American Menopausal Society 2022 guidelines where they have a really good analysis of available data. And the calculated 5-year risks for women 50 to 59. This is something we did for the Endocrine Society guideline. It just helps me think about it, or when I'm presenting it to patients. If you think I'm going to treat 1,000 women for 5 years, women in their 50s with no contraindications, what is going to happen? Combined therapy, this is using conjugated estrogen and medroxyprogesterone acetate. We don't use either of these very often anymore, but you see about an additional 1 in 200 case. Unopposed estrogen, so there was a reduction, and that reduction persisted 18 years after follow-up. Doesn't mean that unopposed estrogen should be used to prevent breast cancer, but a colleague, Dick Santon, who I'm sure you know, he calculates that if you use unopposed estrogen, eventually you're going to see an increased risk of breast cancer, but it might not be until 15 years, 20 years. But when it happens, the rise is going to be logarithmic. I don't know how he did that calculation, but I absolutely believe him. There's some regimens that may be associated with a lower risk. There's no trial data to help us here. It's all observational. Micronized progesterone versus medroxyprogesterone acetate using lower doses. You probably all remember back in the day, every single woman with symptoms got conjugated estrogens, same dose, 0.625 milligrams, whether she needed it or not. But we followed women the same way we do now, just clinically. Are your hot flashes gone? If not, you go up on the dose. But lower doses are now encouraged. If you were using conjugated estrogen, you'd use 0.3, oral estradiol 1 milligram, and I'll come back in a minute to transdermals. And with transdermals, you don't see an increase in breast cell proliferation. These are biopsy studies, or mammographic density. Does that translate into a lower risk? Maybe, but we don't know that. Cognitive function and dementia. I just want to do a time check. I don't see. Wait, time. 8:34. Thank you. Cognitive function. In my heart of hearts, I feel like estrogen plays a role in improving cognitive or maintaining cognitive function and preventing dementia, but it's just impossible to demonstrate that. The WHI did a sub-study in women, over 70, like 70 to 89, and showed an increased risk of dementia. In retrospect, it was likely vascular dementia, a lot of mini strokes. You start with a woman with 75, never been on estrogen, has, plaque, vulnerable plaque, heart, atherosclerosis. Oral estrogen has many effects, many beneficial, but it's, thrombogenic, it's inflammatory. So you probably, maybe, you see the MIs in the WHI and possibly many small strokes, but no evidence that it causes Alzheimer's disease, for example. There's some evidence for a critical window timing hypothesis. If you start immediately after menopause, maybe there's a protective effect. It's so hard to demonstrate any change in cognitive function because the tools are rather crude unless you're really using domain-specific cognitive testing. In general, you're starting with a high-functioning population of women who enter in these trials. You give estrogen, their cognitive function is up here. There's nothing I can think of that's going to make it any higher. We do know that on verbal learning tasks, women outperform men at all ages until menopause, and then they're equal. Some people don't like that data, and there's not abundant data. There's not, but there's domain-specific differences. I was involved in with some studies looking at estrogen women, and we put them in doing functional MR. Definitely, there's a change when you give estrogen, different parts lighting up and stuff. But does that translate into anything clinically important? We don't know. Yes. Yes, and the test that we had them do, it was just that they were balancing checkbooks and doing all this stuff. It was really kind of silly. Other considerations, gallbladder disease increase if you give oral estrogens. Ovarian cancer got a lot of attention. It's not, it shouldn't drive your decision making because there's probably no excess risk. Same with lung cancer. Colorectal cancer, maybe a small decrease with combined therapy, again, using the WHI regimen, but no long-term effect. Meningiomas, neurosurgeons will never, ever let a patient with a meningioma take hormone therapy. But if there's an effect on meningioma growth, it's progestins rather than estrogens, but it's still typically avoided. All right. So first choice of estrogen is 17-beta estradiol, the same estrogen the ovary makes. And, many years ago, nobody had an orally active preparation. So it turns out what you have to do is micronize it. So I don't know exactly how you do that, except you smash it into little teeny particles. I'm sure you know more about this than I do. But that is what we recommend as first choice. Low doses. Transdermal has many benefits over oral, but not everyone needs a transdermal preparation. They're more expensive, very expensive. I've spent a lot of time, I'm sure all of you do, doing prior authorizations if you want to give a woman a patch versus oral. Progestins, micronized progesterone, absolutely the progestin of choice compared to medroxyprogesterone. Medroxyprogesterone, again, was a progestin in the WHI, associated with greater breast cancer risk, associated with greater vascular complications. So micronized progesterone is neutral. You give estrogen, then add micronized progesterone. You see vasodilatation with estradiol, and micronized progesterone does not antagonize that. It does not antagonize the impact on lipids, carbohydrate metabolism, et cetera. Medroxyprogesterone acetate does. Cyclic versus continuous administration, it depends where the patient is in her menopausal stage. So what are the advantages of transdermals? Less effect on clotting factors, triglycerides, gallbladder disease, CRP, SHBG. Lower risk of venous thromboembolism, stroke, mammographic density, as I already mentioned. So it's most important to use a transdermal in someone with underlying hypertriglyceridemia. Give oral estrogen to that patient, you run into big problems. Women with gallbladder disease or women who are at risk for thromboembolism or cardiovascular disease. Patch irritation is pretty unusual. I don't know what your experience has been, but with the newer preparations, these matrix patches are really designed to have, they're very small, and they're very rarely do they cause a skin rash. Micronized progesterone is bioidentical. The term bioidentical simply means structurally the same as what the ovary makes. Bioidentical is not the same as compounded bioidentical hormones. That's sort of a type of practice and approach. Progesterone, as I already mentioned, has a favorable metabolic effect, maybe less breast cancer, but a lot of women cannot tolerate micronized progesterone because of the mood side effects. Usually, if you give it continuously, they do fine, but if you give it in a cyclic fashion, not so great because you're recreating PMS. Just like, luteal phase, no progesterone, progesterone goes up, comes down. In a cyclic regimen, the woman is on just estrogen and then a big blast of progesterone for 12 days or so, and it can cause a lot of mood side effects. But the problem with giving continuous progesterone is that in women who are still have endogenous ovarian function, they're intermittently making estrogen or having ovulations, they will bleed constantly. And it was a big problem in the WHI. Continuous progestin works beautifully once the patient is truly postmenopausal. But we sort of agree that maybe 1 to 2 years since the final menstrual period, you're unlikely to see any follicular development or estradiol secretion. And that's when you use the continuous regimen. If not tolerated, levonorgestrel intrauterine devices. In Europe, they have a really low dose option for menopausal women. We don't have that in the United States. But all of our gynecology colleagues now will offer this. You want to use the lowest possible dose. Women don't need the contraceptive dose of levonorgestrel. Quarterly progestins, giving it every 3rd month or every fourth month, is not protective in trial after trial after trial. I bet it is protective as we use lower and lower doses, but those data are not available. And then there is a combined regimen of conjugated estrogens with a selective estrogen receptor modulator. And I almost never prescribe this, but it can be good in somebody who cannot tolerate a progestin because they don't need to take any progesterone. The SERM antagonizes the estrogen effect on the endometrium. That's why you don't need progesterone. My reluctance is that both of these, they're oral, 2 oral drugs, and both are associated with an increased risk of venous thromboembolism. There's no evidence yet that this is an additive effect or that you see a crazy high risk of DVT or PE, but it's in the back of my mind. I have concerns. So how do you give it for women who present in the early transition or they're newly menopausal? I try and start low if their symptoms are not severe, and then titrate up as needed. Women get relief within 3 to 4 weeks in general. If they come back or contact you a month after you've started a 25 microgram patch and they're having still persistent symptoms, then go up to the next dose. Women who present with very severe symptoms, I start them right at 50 micrograms to really get them to a point of wellness as soon as possible. When they're in the transition, we're sort of forced to use cyclic. If you're going to give an oral progesterone, micronized progesterone, the dose is 200 milligrams given at the beginning of the calendar month. This population, and women in the transition, a low-dose oral contraceptive can be a great option. But you should avoid it in women with obesity. But in non-obese, non-smoking women, a 20 microgram pill, 20 micrograms of ethinyl estradiol, it can be great. Or there's also a 10 microgram preparation. And the potential advantage is it provides contraception. It manages irregular bleeding, heavy bleeding. It treats their hot flashes. One thing to note, if you use a birth control pill, is give it continuously. If you give 21 days on, a week off, their hot flashes come back during that placebo week. So you give straight hormones day in, day out. Once they're truly postmenopausal, similar dosing depending on the severity of symptoms. and you give the progesterone continuously, 100 milligrams. We usually give it at bedtime. There's no evidence that that's really that much better. But if someone's going to have side effects, it's always better to give it at night. Oral estradiol is absolutely fine for healthy women without risks. You don't get the same 24-hour a day sort of stable estradiol levels. Estradiol peaks after about 4 to 6 hours and then declines. But for most women, it's absolutely fine, and it's far less expensive. Women with primary ovarian insufficiency, POI, formerly called premature ovarian failure. We abandoned that term many years ago, got rid of the term failure because it's a devastating diagnosis, but then to have that failure, attached to your diagnosis was very, very hard. So it's menopause before 40. These women should be on hormone therapy until the average age of menopause to prevent all the complications associated with early estrogen deprivation. We typically use a higher dose of estrogen, and why? It's based on the normal pattern of ovarian estradiol secretion. In our group, we have all these normative data studies, women who've had their daily bloods drawn across cycles, hundreds and hundreds, and you just do the area under the curve for a cycle, and it's roughly the equivalent of 100 micrograms of transdermal estradiol every day, or 2 milligrams of oral. Some women prefer an oral contraceptive, young women, which is totally fine. And for women with early menopause is defined as menopause between the ages or over 40, less than age 45. We always ignored this group, but now it's an important group. It's important to identify them and treat them. Duration. The standard use is up to 5 years. We all learned that if you're going to give hormone therapy, use the lowest dose possible for the shortest duration possible. And that isn't ideal for women who are going to have long duration hot flashes. When you stop, should you taper or just go cold turkey? The trial suggests it doesn't matter. In my practice, anecdotally, going cold turkey really, whenever you give estrogen, whatever the patient's diagnosis is, if you give estrogen and withdraw it suddenly, you're going to precipitate hot flashes. So by tapering, if you can avoid those bad hot flashes, it's a good idea. You can taper any way you want. It can be over a month, 3 months, a year. I base it on how severe the hot flashes were before we started. So there's no rules. Extended use. The North American Menopausal Society, the American College of OB/GYN, very conservative group in general, they both have come out and said extended use beyond age 60, beyond age 65 is reasonable, depending on the patient. If you're low risk for cardiovascular disease, breast cancer, every time you come off, every time you taper and stop, the symptoms are too severe and you go back on. If for that scenario, whenever I restart, I try and use a lower dose of estrogen. And when I'm tapering, I add a non-hormonal drug, for example, gabapentin or an SSRI. Now we've got fezolinetant that I'll say a word about. If you go back on, you just periodically wean and see how the patients do. We don't know how to predict when they're going to get to the end of their final hot flash. Women often think that if you treat with hormone therapy, you are resetting the clock. So they present at age 50, and if you give them hormone therapy for 5 years, the myth is that I'm going to go through menopause again at 55 and hot flashes start all over again. But that's certainly not the case. So all sorts of non-pharmacologic treatments. I would refer you to the North American Menopausal Society 2023 guideline on non-hormonal agents. But they did a systematic review and meta-analysis of everything that's been looked at. And one of the big surprises is that now they no longer recommend sort of the lifestyle things that we always tell women to do, like dress in layers, put a fan on, all that stuff. It's no better than not dressing in layers or having a fan. So, like, who knew? So, but whatever. Hypnosis, maybe one study, maybe there's a slight benefit compared to placebo. Mindfulness training, meditation, exercise, in general, no better than placebo. Placebo has a pretty important effect on hot flashes, as it does on many symptoms. Acupuncture, both acupuncture and sham acupuncture work pretty well. Um, so I have a lot of patients who use it. It's just, when somebody is really symptomatic, whatever they can do to make themselves feel better, I'm very supportive. Cognitive behavioral therapy, benefit for hot flashes, probably not, but insomnia perhaps. This is an acupuncture trial back in the day, and the red is sham acupuncture, and the black dotted lines are real acupuncture, and you can see they're virtually identical. Phytoestrogens and black cohosh, herbal therapies. In general, no appreciable benefit compared to placebo, but women use them. We used to be so worried because these are all estrogen agonists. They bind to the estrogen receptor. In breast cancer patients, would it increase the risk of recurrence? Probably not. Black cohosh, we used to think there was a risk of hepatotoxicity. It looks like there isn't. So it likely ineffective for the hot flashes. We don't think it's harmful. All of my breast cancer patients use it, and I've sort of given up trying to disavow them because if it makes them feel better, I think it's reasonable. Here's one trial of soy versus placebo on hot flashes, and you can see there the reduction in hot flashes overlaps. SSRIs and SNRIs, definitely better than placebo. Nowhere near the impact of estrogen. But there's only one study looking at SSRIs or gabapentin, for example, compared to estrogen. But my suggestion is to use citalopram or escitalopram in these doses. And Charles Loprinzi at the Mayo has done all of the trials of all these drugs in women without breast cancer, with breast cancer, and these are his go-to as well. Paroxetine, I tend not to use it. There is a FDA-approved type of paroxetine that's very expensive, hard to get approved. But the reason I avoid paroxetine is I'm usually using it in women with breast cancer. They're on tamoxifen. The SSRIs block, or they're inhibitors of CYP2D6. Tamoxifen has to be metabolized to endoxifen to have its biologic effect. So you certainly don't want to block that. There's no evidence that if you give paroxetine by mistake and someone's on tamoxifen that the risk of recurrence is higher, but in general, we suggest not using it. Sertraline, fluoxetine have a little bit of effect, but they're not as effective as citalopram, escitalopram. Everybody used to use venlafaxine, Effexor, as first-line agent. I almost never use it anymore unless the patient's already on it, and it's because it has many more side effects and the risk of withdrawal symptoms. Gabapentin, I love gabapentin for women who have primarily hot flashes at night. Really quite effective. And I give the entire dose an hour before bedtime, and I let women titrate themselves up. I usually start with 100 milligram capsules. They may take 100 milligrams for a few nights, no effect, go to 200, 300, 400. The trials looked at 900 milligrams, 300 TID. I don't give it that way because of the side effect of sleepiness. Clonidine, better than placebo. I never use it anymore because of side effects. Oxybutynin, also better than placebo, but the side effects here too are pretty difficult, dry mouth, and there is some concern about dementia in older patients who use it. And here's a trial of gabapentin, placebo at the top, reduction in hot flash score, gabapentin here. This is during the double-blind study. And what you see, then there's an open label study that continued. And here you see such a typical thing in randomized clinical trials, regression to the mean. So it looks really great here. And then eventually, not so different. The new drug, new kid on the block, is fezolinetant. And this is a schematic of what's happening, above the pituitary. We now think that we understand the mechanisms or pathophysiology of hot flashes. We used to think it was LH pulses. No. We used to think it was GnRH pulses. No. It's at levels that are higher. So we know that neurokinin B agonists activate these KNDy neurons and induce hot flashes. Neurokinin 3 receptor antagonists reduce hot flashes. So a lot of attention on this class of drug. Just approved in the United States, fezolinetant at a dose of 45 milligrams. I can't remember the trade name. It's advertised constantly. But so it's better than placebo, as shown here. Here's 30 milligrams, 45 milligrams. This is the dose that was chosen versus placebo. Anecdotally, my breast cancer patients who have been able to get it do like it. There are several problems with it. At least in our area, a lot of the pharmacies still don't stock it. They're waiting to see if people are going to order it, and then when enough people order it, they'll stock it. So we'll see. And liver toxicity in a small number of patients, and a possibility of more neoplasms. I'm going to skip genitourinary syndrome of menopause, but it's, as endocrinologists and internists, it's really important that we address it, ask about it. It's so easy to treat with vaginal estrogen. It's completely safe. Women can take it till they're 100 years old, and it improves sexual function. Testosterone therapy, far more controversial. After menopause, the ovary stops secreting estradiol, but it continues to make testosterone. Production rates are lower. Is there such thing as an androgen deficiency syndrome in women? We honestly don't know. There's no, androgens decline beginning at about age 30. There's no specific drop after menopause, but a decline in libido is fairly common in women. But all of the clinical trials that were done in women were based on the medical model of libido. So giving high doses of testosterone back to get, super physiologic serum concentrations. And in that setting, you see a small improvement in sexual function, primarily in an increase in sexual fantasies, one per month, for example. But the downside is pretty important, the side effects of testosterone. We have no approved product here in the United States for the reasons, based on the trials. And we don't recommend it at all for premenopausal women, but for some postmenopausal women, there's a small subset in whom we know it helps. And those are women who have hypoactive sexual desire disorder. The typical scenario is a woman undergoes natural menopause and boom, libido goes from 100 to 0. Or surgical menopause, where you're removing the ovaries and the source of testosterone. And in that setting, it makes sense. It's really important to look at other factors that affect sexual function. Many medications affect it. Any chronic illness, relationships, sexual dysfunction in the partner. So I never even think about testosterone therapy till I've really exhausted these options. I always make sure they're on vaginal estrogen therapy. Improve blood flow. If you improve blood flow, you improve sensation. It's sort of, I view it as sort of a platform to get back in the game. No vaginal estrogen, it's not, you see pain, diminished responsiveness. DHEA, ineffective, no role. I already mentioned we have no regimens. Australia is the only place where they have an approved testosterone regimen. They have a little gel. So if you're going to give it, first, I make sure there's nothing else going on. This is the one time I might use a compounded therapy for testosterone. You have to make sure it's a great compounding pharmacy. And the doses, you use a 1% formulation and you apply 0.5 gram to the arms, abdomen, legs. Stay away from testosterone pellets, really popular now. Big high doses, the superphysiologic dose is maintained for at least a month. It's painful, the insertion. Women really don't like it. You can't take it back out. So I really discourage that. There are a lot of adverse effects because if we're giving, too much testosterone, it gets converted to estradiol. You see vaginal bleeding, endometrial hyperplasia. You also see acne, hirsutism. Rarely do you get virilization, but if you're using too much, you can. And if you end up starting it, really monitor serum testosterone. I almost never start it, but I have a lot of women who come to me and they're already on it. In summary, we are undertreating women. Urgent need for better education. Recently menopausal women are terrific candidates, most women. No appreciable increase in breast cancer based on the NAMS analysis. And we use transdermal estradiol, oral micronized progesterone. There are many non-hormonal options. The newest is the fezolinetant. But I think, it looks like it's not as effective as estrogen. They will never do that trial. So we'll never know. So I spoke longer than I expected to, but now it's 9 o'clock. But do we have time for questions? And I thank you so much, everyone.
Great. Many, many thanks, Dr. Martin. I do want to acknowledge it's 9 o'clock. So anybody in the room who needs to get on with their day, please feel free. I'm going to go ahead and field just one question from online. This listener wonders about thoughts regarding extended use or perhaps even initiation later after menopause, like 10 to 15 years later, and specifically has women asking for help with sleep, and occasionally has women who have had primary ovarian insufficiency who were never offered hormones initially. Is there now a role several years later?
Okay, a lot of parts of that question. Primary ovarian insufficiency, never too late. I see many of these women, and a lot of them were not offered it in the post-WHI era. If they've had no estrogen for 15 years, we might guess that perhaps they've already have some. You won't look at their bone density. They may already have some atherosclerosis. I would probably use a transdermal, but never too late. There's no reason to think that at age 70 or 80 that I need to treat them more than other menopausal women. Longer duration, extended duration, yes, it really is okay, depending on the patient. Low risk for complications. I've spent so much time, and I'm sure you guys do. You taper and stop, see how they do, back on, and I believe that these are the women who their hot flashes are not going to be gone for 20, 25 years. And I feel comfortable doing that, as long as you're monitoring them carefully. And someone who I do see women who come in or get referred, they're 70, 75, they've never been on hormone therapy. It's often symptoms that are not specific to estrogen deficiency, in which case I don't start it. But hot flashes can come back in the setting of illness, death of a partner, life stressors. And so I have enough women who are really suffering, and I'm willing to bite the bullet, give a transdermal at a really low dose, and it's diagnostic, therapeutic. If they feel better, they feel better, and all good.
Great. Well, thank you so much. Such a comprehensive talk. Do you want to acknowledge that we're at time? Perhaps I'd invite anybody in the room down to speak a moment with Dr. Martin if she's willing to stay.
Happy to.
Thank you.